So, dear Dr. Joannet, dear Dr. Mador, dear researchers, dear clinicians, clinical and research professionals, and dear trainees. So my name is Rory Monchi. I'm the scientific director of the Montreal Geriatric University Institute Research Center, the CRIUGM. And I'm very honored to welcome, together with Dr. Marie-Jeanne Kergoat, Dr. Sharon Straus at the CRIUGM and the Institut Universitaire de Gériatrie de Montréal of the Centre-Sud de Montréal. Dr. Sharon Straus is a geriatrician and clinical epidemiologist from the Department of Medicine at the University of Toronto. She's also the director of the Knowledge Translation Program and physician-in-chief at St. Michael's Hospital. She published more than 650 peer-reviewed publications. Since 2015, she has consistently been in the top 1% of highly cited clinical researchers and has an H index of 126. She's a fellow of the Royal Society of Canada, the Canadian Academy of Health Sciences, and a member of the Order of Canada. As you know, Dr. Straus is in Montreal as she's receiving a Doctor honoris causa from the Université de Montréal in recognition of her exceptional career in her field that has been recognized around the world. Congratulations again. This morning, we will have the pleasure to listen to Dr. Straus, who will be speaking about linking research to practice, knowledge translation in geriatric medicine. After the talks, we will welcome Dr. Diana Cruz, who's an associate researcher at the CRIUGM and professor at the Department of Family and Emergency Medicine at Université de Montréal, who will present on who will give a presentation entitled From Conception to Implementation, a new clinical tool for post-fall assessment in long-term care. After that, we'll have the occasion to exchange with Dr. Straus, initially on the presentations and hopefully more broadly afterwards. So thank you very much, Dr. Straus, again. Welcome.
Thank you very much for that kind introduction, and thanks so much for the opportunity to spend some time with all of you today. And apologies for not speaking French. My French is très mauvais, so apologies. Before I start, I do want to, let me see if I can get this to work. Did I not use the down arrow? Oh. There we go. Thank you. Thank you so much. We're very excited that we got to use this new laptop. So, but we're all trying to figure it out now. So before I start, I do want to acknowledge that I am based in Toronto, and I'm very grateful to work on land that we feel a tremendous responsibility to care for. We are working on land that is covered by Treaty 13, which includes the Mississaugas of the Credit, and it also includes the Dish with One Spoon Treaty, which is about how we all have a responsibility to look after and care for each other and care for the land. And that includes the Anishinaabe, the Mississaugas of the Credit, and the Haudenosaunee. As a white settler, I also want to acknowledge that I am an uninvited white settler onto this land. And our program itself is very committed to working on the path of truth and reconciliation. And in particular, one of the things that we have all committed to, in addition to engaging with Indigenous partners on our various projects and learning from them and with them, is also to be an ally and to partner with different organizations within our community that provide care for Indigenous community members. In recognition of this opportunity of spending time with you today, I also donated to Anishinaabe Health in recognition. And so I thank all of you for allowing me the opportunity. Just to give you an example of my competing interests, I don't take money from anybody. I'm kind of boring, but but I do work with a lot of different journals. And I have also written books on knowledge translation and mentorship, but I don't receive any royalties from those. Those go to a fund for trainees, and I don't have any authority over that. So just to keep that in mind. This is hopefully what we're going to talk about today. And if there's anything that comes up along the way that maybe I haven't talked about or that you'd like to hear about, please feel free to stop me and we can chat. So I subtitled this talk why, basically, I think I have the best job in the world. And I honestly can't believe that I get paid to do what I get to do every single day. I get to look after older adults and be involved with their families, and they are the source of the research questions that I ask. Because as you know, every time we see a patient, different questions come up. Every clinical encounter is an opportunity to ask and answer questions. Some of those questions are going to have answers, and then that leads to excellent patient care. But we also know that some of those questions don't have answers, and that's where our research starts. And so that's why I think that we're incredibly fortunate to do what we get to do. This is where I kind of started in my research career, and I trained in clinical medicine and geriatric medicine, and then went away to do my research training in the UK. And one of the things I was interested in was, how do we bring evidence to the point of care and to the clinical interactions? And at the time when I was doing my fellowship, we didn't have computers on the wards. So I often say it was when the earth was still cooling. And this is what I had to build to bring evidence to the point of decision making. So you can see we had a laptop computer, very similar to the one that you have here. But we also had I brought along a projector and a computer screen. And every time there was a clinical question, when we were at the bedside, we would search for the evidence and see whether or not it made a difference in what we were doing. And it did make a difference. So if you bring evidence to the point of care, to the point of decision-making, when the questions come up, we use it. And when we took the cart away, questions were still coming up, but we weren't getting the answers to that. But it did stimulate my interest in, well, we could do it at the individual patient clinician level, but what do you do at the unit level, at the hospital level, at the provincial level, at the country level? How do you do that knowledge implementation? And I'm not sure if people have seen the series in The Lancet a few years ago on how much research is wasted. And so it kind of got me interested in thinking about all the research that is done that doesn't get used in practice and policy. And in the research series in The Lancet, it's estimated that about 3/4 of what research is produced globally is wasted. And if you think about it, that's public dollars to the most part that's funding the research. And if you think about our moral and ethical imperative to make sure that we don't waste public dollars. And so it's really, I think the onus is on us to make sure that we look at the leakage in that research pipeline. And it's everything from, are the questions that we're asking the relevant ones? Are we designing our studies appropriately so that the methods are rigorous? Are we then disseminating the evidence? And is the evidence being used in practice and policy? And you can see there's potential for leakage at every step along the way. So it got me interested in thinking about how do we do that? And the first kind of step in all of the knowledge translation processes is always kind of thinking about, well, what's the theory, model, or framework that I'm gonna use? And one of the things that I really struggled with as a learner was, how do you pick a theory, model, or framework? And if you look at kind of just in the knowledge translation or implementation science field, there are several hundred theories, models, and frameworks that you could pick. And we don't need another new one, but we need to be able to test the ones that are there. And Lisa Striffler, who just recently finished her PhD with me, developed this tool. If anybody's interested in knowledge translation work, this is a tool to help you find a theory, model, and framework to guide your knowledge translation work. So it asks you a few questions about what the project is that you're interested in, what's the question that you're interested in trying to answer, and it provides you with information about a theory, model, or framework that you could potentially use. And it gives you information on the type of theory, model, or framework, gives you links to the relevant articles as well. So thinking about all those different theories, models, and frameworks, one of the ones that I use a lot is the knowledge to action framework. It's based on a theories of planned action, or how do we deliberately engineer behavior change. And that's really what we're trying to do in knowledge translation or implementation science, is we want to change behavior. And this is something that we worked on with Ian Graham and Jacqueline Titre many years ago. And looking at the review of all the theories of planned action, we came up with the action cycle around the outside, which is about how do we change behavior. But one of the things that was missing from a lot of these theories was the evidence piece. And we can't do knowledge translation without the knowledge. And that's really where everything starts. And the primary research generation, then we do the knowledge synthesis, and then create knowledge tools and products. And together, then they create the knowledge to action cycle. So I'm going to illustrate kind of how we work and do our various projects, starting off with, we typically start with systematic reviews, and we do all different types of knowledge synthesis, including network meta-analysis. This is one, and I selected this one because it's on falls prevention, and I know we're gonna hear about a falls prevention intervention shortly. Network meta-analysis is basically a tool that we can use that allows us to look at all interventions. So as you know, when we do systematic reviews, we try and look at all the evidence. Meta-analysis is a pairwise statistical analysis that we can do to compare two different interventions. And network meta-analysis makes sure that we don't have to lose any of that data on all of the different interventions. It allows us to look at all the interventions together, both direct and indirect evidence. And so we look at creating these different relationships like what you've seen here. And so we've done now a number of these on complex interventions, but in particular, one of the ones I wanted to flag was on preventing falls in older adults. And in particular, because this includes strategies that are targeting the older adults and strategies that are targeting the team, caring with the older adult and their caregivers. Now, I showed you that diagram with like lots of messy lines. It actually boils down to this one figure. This is called a rank heat plot. And this is a way that we've developed with R.G. Veroniki, who's a biostatistician who did a postdoc with me, developed to create an approach to illustrating results of those hundreds of thousands of analyses that we did. This is what it looks like. And as a clinician then, what I can do is I can say, talk to my patient, find out which outcomes are most of interest to them. Is it preventing fractures? Is it preventing falls? Each one of these different circles is a different outcome. And the green is the most effective interventions. The red are the ones that are not effective. And so working then that way, I can translate all of those thousands of articles into this one figure to be able to say and talk to my patient, talk to their families, talk to the policymakers about which outcomes are we most interested in, and it helps us target then which interventions we want to focus on. So that's kind of that funnel piece that's in the middle of the knowledge to action cycle. And in particular, if you look at where the green was in that figure, this is kind of if we wanted to zoom in on it. And I wanted to highlight a couple things. First of all, a lot of times we think in knowledge translation work that, well, if I just tell people what to do, it'll fix the problem and everybody will do it. If I target the clinicians, it'll fix the problem. Time and time again, when we've done work like this, when we've done network meta-analysis, when we've tried to tease out the different components and the active ingredients, the most effective interventions are the ones that target the patients and the team changes rather than the clinicians alone. And you can see that from this diagram, from this table here again. And we've seen this with falls prevention interventions, with case management interventions, with a review that we've done on frequent users of the healthcare system. It all comes down to targeting patients and team changes. So once we've done that, then we want to focus on the action cycle. So we've got this evidence, and now what are we going to do to try and implement it? And it all comes down to a few questions. So we've got this evidence-based practice. We then need to think about who needs to change their practice. we need to think about why would they change their practice? How can we help them change their practice? And then how are we going to evaluate that and sustain it over time? So it really allows us to think about then those 5 questions. And at each step along the way, we've developed different tools to facilitate each of those steps. And these are all freely available if anybody wants to access them. So thinking about mobilizing older adults, and I'm going to illustrate with that as a project. So as we all know, when older adults are admitted to the hospital, actually when anybody's admitted to the hospital, what's the first thing we do? We put them to bed. And as you all know, that you know, when older adults in particular are in bed, we increase their risk of deconditioning. They lose functional status. And we've got all this evidence saying that mobilizing older adults is a good thing. So we've got the what. So we've got the clinical evidence here. This is the 3 key messages that we wanted to implement, including we did the falls review because one of the commonest barriers to implementing is people are always worried about fall risk if we're mobilizing people. So it fed into that. And then we developed then these are the implementation strategies. So this is the how we get people to mobilize. So we've got the what and the how, and then we need to work on all of the different strategies to engage people in doing the how. So to illustrate how we did this, we started off doing it as a project in 4 academic hospitals in Toronto, then it went to 14, then it went to 65, then it went to 165, then it went to different provinces. But this was kind of the first piece of it. And we did it as a very simple, kind of straightforward interrupted time series that we used mixed methods, qualitative and quantitative, and we targeted older adults on in acute medicine inpatient units. To develop the intervention, we started off looking at barriers and facilitators. So we interviewed people, interviewed clinicians and patients and family members about barriers and facilitators to mobility. And you can see here some of the examples that came up. And then once we do that, then we've created this tool called a select tool that helps you map the why and the how. So if we've identified this barrier, like a lot of people say, well, it's not my job to move patients. That's the job for the physiotherapist, you know, and a lot of times, you know, it's a physician or family members saying that's not my job to do that. And so one of the things that we are able to do is we can map this to the domain of social professional role within the theoretical domains framework. And that tells us then what interventions we could potentially use. So this maps to the social professional role. And we know that then if we think about persuasion or role modeling, those are interventions that we could consider to overcome that barrier. Or similarly, and I'm sure you've all heard of this, when you know people are heard this when you're talking to people, that people always say, if I get the patient up more, they're going to be more likely to fall. And absolutely, if you're upright, you're going to be more likely to fall than if you're lying down. But the consequences of lying down are much more significant. And so this is something again that we can tackle with persuasion and modeling. So the next step in our tool then allows you then to move from those barriers and facilitators and identifying the domain within the theoretical domains framework to then developing your implementation strategy. And so it's a kind of a step-by-step approach to think about what do I need to do at the level of the providers, at the level of the patients, at the level of the organization, and develop then your implementation strategies. So we did this across multiple units and in multiple hospitals, and our outcome was mobilization, and we had observers go onto the units at random points in time, multiple days of the week, and record mobilization. We also looked at some secondary outcomes, including falls and quality of life and length of stay. But across the board, the patient mobilization improved. We also found that we had shorter length of stay within our hospitals, and we were also able to show that where there was more mobilization, they had the shortest length of stay. We weren't able to collect much data on falls because we didn't have, there weren't that many falls. So, which I think is a good outcome on its own. And so we weren't able to include that. But subsequently then, what we did was develop tools then to inform sustainability, to inform scalability, that were then used in other hospitals, in other provinces, and in other countries. So now there's a modules and workbooks then on the Move On project, and we were able to align it with, because we knew provincially we were going to have to implement a mobility initiative at all the hospitals. So we were able to align it, and we knew that was coming down the pathway. Another project then that was aligned with this was, again, one of the things that we identified was, as you all know, we can't create an intervention that's going to be the same for every single individual, because everybody has different experiences, a different context, you know, whether that's race or language or age, education level, you know, the experiences of the context in which they live. And so we wanted to do some work based on the Move On project to understand, how do we take an intersectional approach to thinking about developing interventions, to think about testing interventions. And this was a team grant then that we got just as we were working on the Move On project, to really help us understand, how can we bring an intersectional lens to knowledge translation. And this really is based on work that Kimberly Crenshaw, and when she coined the term in the US more than 25 years ago, recognizing that people's experiences are shaped by a combination of things. And it's not just an additive, it's a compounding of factors, and that they also occur within structures of systems of power and oppression and privilege, and being able to understand all of those interactions. And so we wanted to use that to help us in developing our implementation strategies as well, so that we really could contextualize it to different individuals. And so it starts with, now we've got exercises that we use whenever we're doing projects. All of our teams come together to really think about, you know, what biases are we bringing to the work that may influence the work that we're doing. You know, not just who's sitting at the table, but whose voices are being heard at the table. Because I think a lot of times we think, well, we've got people sitting at the table, you know, we've got diversity around the table, but are those voices being heard at the table? And so giving us that opportunity to make sure that, you know, at every meeting that we have, at every interaction that we consider that. And in particular, thinking about what role we are playing in that. So if anybody's interested, then we then modified our tools and our theories and our models to use that intersectional lens, and right from when we conceive of a project all the way through to dissemination and implementation. And if anybody's interested, you can see that there. So as another example to show kind of how we can bring implementation science or knowledge translation together with, you know, across all the pillars of research. You know, I'm a clinical epidemiologist. I am not a basic science researcher. And, you know, one of the things that changed during COVID is it really did kind of, you know, force us to move out of our silos and encouraged us to think across all the different types of research about how we could tackle these really important questions together, and how we could learn from each other and tackle these issues. And so one of the things that we did during COVID was, how do we support those living and working in congregate living settings? So long-term care, retirement homes, and shelters. And kind of near the very beginning of the COVID pandemic, I got a phone call. We worked with a lot of long-term care homes. Got a phone call. They were really struggling with, how do you do an NP swab in somebody living with dementia who's agitated? And, you know, it's not pleasant. None of us liked having something shoved up our nose. And and they were really struggling with, how do you do this? And so that was kind of our first kind of project to think about and to develop a knowledge translation strategy for. How do you do this? So that, you know, it's not so terrifying for the individual or stressful for the staff who's trying to do it and is trying to do it in, you know, painlessly. So that kind of led us to this work. And then around that same time, the WHO asked for a scoping review on guidance on mitigating outbreaks in long-term care. And so we did that to inform the first guidance. And so started thinking about this and started then working on a project where it was very much focused on answering the questions that were most relevant to the people working and living in the long-term care homes and in the congregate care settings, and creating a rapid response unit and an implementation approach to tackling that. And so we got some funding from FAC and the COVID Immunity Task Force to then bring a group of people together. And it allowed us to do research across all the pillars, all the 4 pillars of research. So we had Anne-Claude Gingras, for example, led us on some of the work around understanding neutralization of the virus. And then we were able to use that when the vaccine came out to help inform when different doses of the vaccine needed to be given in long-term care. We're able to look at the role of health equity and what factors were associated with COVID infection, not just within the long-term care homes, but in the neighborhoods where the long-term care home staff lived. And so we're able to use that data. And then alongside doing the implementation work then. And so using all of that evidence together then to develop implementation strategies. And you know, since we started this now, we've got a large network of retirement homes, long-term care homes, and shelters. And we did this kind of in lots of different studies. And as you've seen from what I presented, I'm a big believer in doing studies within studies within studies to make us efficient in what we're doing. And overall, we designed this as an implementation study that was going to be informed by Pillar 1 and Pillar 2 research. And that we were going to do this as a controlled interrupted time series across multiple long-term care homes, and including 4 populations. So we had the residents of the long-term care homes, we had the staff within the long-term care homes, we had the family members of the residents in the long-term care homes, and we had the people that the staff lived with. So we had 4 populations that we were able to bring together and answer the questions that were relevant to them. So we've been doing this across 72 long-term care homes and retirement homes in Ontario. And we've got kind of a high intensity implementation group and one that's kind of more self-directed. And this was based on their needs. And it gradually expanded to, we got calls from the City of Toronto asking us if we would deliver this in the shelter context as well, because we're seeing, as you all know, we're seeing more and more older adults who are experiencing homelessness and using the shelter system. And in particular, during COVID, we found this. And so we extended it to that population as well. And it kind of focused on 3 components. So infection prevention control was the first one. But then as the vaccine came available, then it included that. And then as the need to really support the well-being of the staff, the long-term care home staff, that became a very prominent component as well. So we started off kind of looking at all the IPAC pieces and developing, it was whatever the long-term care homes needed, we would develop, we would work on with them and make it available and support their implementation. We were also able to access money from Healthcare Excellence Canada to support the implementation with them of those things. We also then created resources to support vaccine uptake, because as we all know, the initial vaccine uptake, it was probably went much more smoothly than subsequent rounds of vaccine uptake, and working with the different organizations and partners to be able to facilitate that. And then as mentioned, one of the key pieces we wanted to do was create wraparound care for the staff working in the long-term care homes. As we all know, that people working in the long-term care homes experience a lot of moral injury, moral distress, and trauma. And wanting to be able to make sure that we could provide wraparound care and facilitate access. So we did studies at the site level, but then also at the individual level. So across each of those 4 different populations, then we were able to do immune studies. And we used that to inform the implementation work, but we also used it to inform the NACI guidelines, as mentioned, on vaccine uptake as well. Just to give you a sense of what the homes look like, we had a mix of for-profit, not-for-profit, and you can see also the number that had 4 bedrooms, as opposed to those that didn't. And to give you an example of some of the different projects that we worked on, and in particular taking that equity lens, we were able to look at, looking across our data, and we were able to do this provincially and then also at a more granular level within our neighborhoods to see, what factors influenced infection, and that was able to be used to inform pop-up clinics for vaccines, for example. But one of the things that you can see here is that where the congregate living setting staff lived, they were more likely to get infections. They were more likely to have a higher household density. They lived in multi-generational households. There was a greater proportion of the individuals within their household who also worked in other essential services. So they were a much higher risk of infection. And one of the things that I think is that is one of the most distressing things is that we really didn't tackle disparities very well in Ontario. And you can see here, this is some of our data that was led by Sharmista Mishra, who's one of our infectious diseases physicians who worked with us on this, mathematical modeler. And you can see that with each wave of the pandemic, who did the worst. So these lines are the deaths, and they're by income. So these are the individuals with the highest income. These are the individuals with the lowest income. And you can see that with each wave of the pandemic, who was hit the hardest, and that we really didn't address as a province. This is the provincial data. As a province, we didn't address the disparities like we should have. This is an example of some of the research then that we did that Anne-Claude and Jen Gomerman led us on around looking at the neutralization assays. And in particular, we did this was data, again, looking at the 4 populations, but this only shows you 2. So these top lines are the staff, and these are the long-term care home residents. And then you've got the Moderna vaccine and the Pfizer vaccine. The salmon color is at 2 to 4 weeks after the dose, and the blue color is at 6 months after the dose. And obviously you want kind of the higher levels, give you an idea of their immunity status. One of the things to flag, though, is if you contrast kind of the neutralization levels here compared to here in our long-term care home residents at 6 months, what the decline is and what the difference is. There's a 480-fold difference. And so first of all, highlighting better response in the staff versus the residents. And again, I'm sure nobody here is surprised. You've all seen this before, but really highlighting the differences and highlighting how frail the older adults are who live in the long-term care home settings. We were able to then do subsequent samples every 6 months. And so we were able to identify then when additional doses of vaccine were needed, we would feed that into the NACI guidelines, but then we would also feed it into our implementation strategies to prepare for the vaccine uptake strategies to help inform that. So it was a way of using the basic science data to inform the implementation work that we were doing. We also did work on wastewater surveillance. And, if you'd asked me 10 years ago as a geriatrician, health services research person, would I be doing wastewater surveillance? And, I would have said no. But one of the things that thought of at the beginning was Rob Delatolo is an amazing engineer working in the University of Ottawa who was doing this for public health in Ottawa. And I phoned him up one day and said, I'd been introduced to him by, and asked him, could you do it at the level of the site? Like, could you do it at a long-term care home level, at a shelter, or at a neighborhood level to help us identify maybe an outbreak sooner, where then we could act? And So with Rob in Ottawa, and then he started doing it in different neighborhoods then. And you can see kind of the different neighborhoods and you know, how different they were in terms of, you know, things like vaccine and vaccine access. We also had differences in terms of social determinants of health, like economic status. And then we also did this with our amazing colleagues at Toronto Metropolitan University, Kim Gilbride and Claire Oswald. And we did this at long-term care homes and shelters that kind of surrounded where we worked, to see if we could then develop implementation strategies to mitigate outbreaks. And this is then where we got a lot of interest from the shelters, because during the first wave of the pandemic, one night, our hospital, we got a busload of people from one of the shelters that works close to our hospital. And we had a busload of people from the shelter who we had to assess for potential COVID and manage. And it was overwhelming. It overwhelmed our emerge department. And so we wanted to figure out, is there a way that we could potentially do better and manage people better so that they didn't have to come into the hospital to do that. And so one of the things we did then is that we now have wastewater surveillance where 3 times a week they sample at these shelters. If there's a signal, that triggers a response within the shelter where they start doing testing. And we were able to get access to rapid multiplex testing, not just for COVID, but for flu and RSV now, and then able to implement treatment strategies and use it to mitigate outbreaks. And so we haven't had the same level of outbreaks within our network that we had in the first wave. And this just illustrates, I'm not expecting you to see the detail, but illustrates that the public health then developed this algorithm of testing and treatment and isolation and appropriate management, depending on if it was COVID or the subsequent years with flu as well. Now, unfortunately, we can also talk about how Ontario just stopped the wastewater, but that's another topic for discussion that we can chat about. But overall, just to give you a sense of kind of what's happened now, this network has kind of created communities of practice now that they're leading, where they are deciding what topics they want to cover. They are leading different initiatives, and it's beyond COVID. It's on things like dealing with racism in the workplace, for example, is a topic that's come up recently. So it's very much something that was born out of COVID, but has continued on in different ways. The last project then that I wanted to speak about was, again, something that grew out of this work. Around the same time that we started this COVID project, well, in 2020, we started an outreach initiative to shelters. And, you know, as a geriatrician, we tend to see people 65 and older. We dropped our age to 50 and older for people in the shelter setting. And we developed this outreach to shelters. And one of the things that unfortunately we found is that a large percentage of them we diagnosed with dementia, previously undiagnosed, and about 2/3 of them meet criteria for long-term care home, but they weren't getting into long-term care, and then for various reasons, which we can talk about. And we've also seen just the exponential growth in the number of people experiencing homelessness, especially since COVID. And that doesn't count the individuals who are precariously housed or awaiting subsidized housing. And there's about 35,000 individuals who are couch surfing, for example, or living with relatives, temporarily. So we really wanted to focus on how do we address this project? And with Jill Alston, who's one of our amazing geriatricians, and Steph Burrell, who's a primary care physician working in the shelter system with us, we recently got a CIHR grant to co-create, implement, and evaluate a long-term care model that includes everything from the built environment. So we've got architecture involved, we've got psychology and sociology and caregivers involved. We've got older adults with experience, lived experience of homelessness involved from the beginning. They're going to be co-creating this. They're going to be driving it, and we're going to implement it and evaluate it across a number of long-term care homes. We initially started this in Toronto, and we had partnered with Amanda Grenier, who was at McGill here, and Tamara Sussman. And now we also are partnering with Lara Nixon and colleagues in Calgary and being able to do this. We're hoping to do this in parallel across 3 different cities and evaluate it and learn together, not just on how we can co-create long-term care for older adults experiencing homelessness, but how can we make shelters a better environment for people? How can we make retirement homes? How can we make supportive housing? So using that same approach, we're hoping to be able to do in this way. So just to add, everything begins and ends with patients. Everything that we do, everything that I think that we do begins and ends with patients. Every time we see a patient, it's an opportunity to ask and answer questions. You know, one of the things I referred to is I honestly do have the best job in the world because I get to work with amazing, amazing people. And I think one of the things that I'm so grateful for is the expertise that they bring. In like me as a geriatrician, there's an element of experience that I can bring. But I also recognize that, you know, we all should have clinical and scientific humility. We can't answer these questions alone as a single discipline, as a single individual. And I'm incredibly grateful to have the opportunity to work with amazing people like all of you in this room are, you know, it's amazing. And I also think that it's a wellness strategy. You know, one of the things that I found during COVID is the ability to try and problem solve. You know, you see a problem and you're trying to solve it. That's a wellness strategy. And I found that was incredibly, incredibly powerful. You know, that was so helpful during COVID. And whether that was in a leadership role that you have, or a research role that you have, or a clinical role that you have, you know, being able to answer questions is a wellness strategy, I think. So having said that, I just want to acknowledge I work with amazing people, and thank you. I'm incredibly honored to be able to chat with all of you today, meet with all of you, and I look forward to hearing about all of your fantastic work. So thank you.
So, thank you, Dr. Straus, for this conference, which through its variety and relevance, give us an overview of the quality of your work, your immense work. We will now give you a 35-minute break. Okay. I'm Marie-Jeanne Kergoat. I'm a senior geriatrician in our geriatric institute. And I could say a senior and a geriatrician and a professor in the Department of Medicine at the University of Montreal. Alors, we took the opportunity of your visit, Dr. Straus, to benefit from your expertise and suggestion to look over a research project which combines medical practice, teaching, research, and dissemination of knowledge. I am pleased to introduce a colleague from our Institut de Gériatrie de Montréal, Dr. Diana Cruz, who, with courage, accepted to submit to your attention a unique research work. She is responsible for the Canadian Family Physician Certification on added competency in family medicine on care of the elderly in the Department of Family and Emergency Medicine at the University of Montreal. In this capacity, over the past 5 years, she has involved her trainees in a marathon research project to develop a clinical tool on post-fall care for long-term care patients. Please let us welcome Diana.
Yeah, that will be better. Okay. Alors, merci beaucoup d'être là tous ce matin. So, thank you very much for the presentation of the report. I also want to apologize for not speaking French, for my terrible French too, and also my terrible in English as well. I'm just going to share the tool with you. So I have some few copies of the tool because it's difficult to see in the computer. So there's some of, but some of them are in English and other in French. So you just can share that. Il y a des copies en français et en anglais, donc je suis préparée pour que ce soit plus facile de les voir. So I'm just going to present this. This is from my residence. So I'm the care of the elderly program director. And this is a project about creating a new tool to assess faults in long-term care. So my co-investigators in this project, so Joan Gériatre and Panama Diaz-Bando here at CRIUGM. So thank you for making this possible. I have no conflicts of interest and I received funding from CRIUGM for this project. So just a brief introduction for why we created this tool. So, most of the tools focus on fall prevention and fall management. So we share it to support clinical outcomes and different quality of care. And variations depend on the severity of the injury and other conditions from the patient, but also on how the medical team responds. So for us, it is important to standardize the practice and to ensure every patient will receive the best possible care. So our solution was to develop a new clinical tool specific for post-fall situations in long-term care settings. The objective was to standardize and facilitate communication between nurses and doctors, and to optimize the precision and response time of post-fall interventions. So, as I mentioned, this was developed by my residents. So each cohort worked in a different phase. And until now, it has been 5 years working on this project. So it took 5 years to complete it. So we had 3 phases in this study. The first one was really focused on creating the tool. And the second phase involved validating the tool. And finally, in the third phase, we test the tool in real-world settings, so our care units. So in the first phase, there were 2 stages. The first one was the literature review. And these were the keywords that we used for the research. So it was about fault, population, evaluation, assessment, trying to find algorithms, decision trees, or patient care planning, and other words that you can see here. So the inclusion criteria for the literature review. So we included studies that were focused on geriatric population, both that were from level 2 phase or involving furniture, and publications in French or English. And comparing about the exclusion criteria, we excluded studies centered on fault prevention, and also studies describing long-term care consequences of falls, as we want to focus on immediate complication within the first 48 hours after a fall. And also assessments that were performed by non-physicians or non-nursing professionals. So this is the diagram chart. So at the beginning we had 445 articles. And then at the end we retained 19 documents. And these 19 documents contain two types of information. So studies on risk factors and consequences of falls, those were 12 articles. And documents on clinical tools, those were 7 documents. And only studies that were statistically significant were retained and based on old ratios. Five tools were identified. So you can see the tool here in this slide. The first one, the post-fall protocol, was a tool that was developed for hospitalization patients. So it was for acute care. Post-fall assessment algorithm was for institutionalized patients, like psychiatric institutions. And the other three, the fall prevention form, the post-fall guidance, and the post-fall decision guidance, were developed for nursing homes or for home. But there was a lot of missing things from this tool. So the first one was the lack of comprehensive focus. So most of the tools either focus only on fall prevention or on specific aspects of post-fall management, but none of them address both prevention and management together. Other thing was the incomplete validation process. So many of these tools have a known or incomplete validation. So there were concerns about their reliability and effectiveness in real-world settings. And also limited scope and application. So these tools are often designed for specific settings and it may not be useful in other contexts. And the last one. So the narrow focus on certain patient groups. So some tools were targeted specific patients populations, and well, it was a problem that there were not all the vulnerable groups who are at risk of falls included. So this is why we decided to use a new tool specific for long-term care. So the 5 tools were compared to a gold standard, which was a post-fall assessment that is used at CHUM Hospital. That is also an acute care unit. They were compared based on these things. So primary evaluation, secondary evaluation, relevant patient history information, patient environment, and post-fall actions. So this is the two comparison tables, and so we're not going to describe all the elements. This one is in French, so I'm sorry for not translating this slide. But it's not intended to pass all the elements, just to show you how we did to compare the 5 tools with the gold standard in black, which was a CHUM assessment. And then we examine all the elements associated with hospitalization for injury. And we only include those that were, again, statistically significant, again, based on all the issues. And even if it was only 1% in the tool, we keep it because we wanted to compare it to the gold standard. So when the element was included, when the element was 3 or more, we included it in the tool. And it was included in the gold standard, agreed with the gold standard. So that was the first part of the literature review, so the first stage. So then after the literature review, we wanted to obtain more information from people working at the per unit. So we performed some interviews with doctors and nurses again. So the objective was to identify communication challenge in managing all victims, and also to determine key clinical observations that were crucial for decision making, for example, when a patient needs to be transferred to the emergency. For the study design, we did 10 structured qualitative interviews lasting 30 minutes, and we asked open questions. The interview was conducted via Zoom by the resident because obviously it was pandemic time, and then it was also recorded. The inclusion criteria for the interviews, so we were looking for nurses working in long-term care units in both units, so cottage and fellowship, and for family doctors doing on-call wards for at least 2 years. The sampling included 6 nurses from day, evening, and night shifts, 1 clinical coordinator that was a nurse also, and 4 family doctors. And then for the analyze, we used thematic analysis of the interview content using interrogate agreements. So there was a research professional doing the verbatim transcriptions, and then they were analyzed by 2 research professionals. So each one at a time analyzed the transcription separately, and then they were correlated by themes to create the thematic tree. So this is what we call an interrogate agreement for the receipts. And the 5 essential themes were identified for the thematic tree. So it was patient characteristics, description of the fall, primary assessment, secondary assessment, and post-fall management. And this is what that you can see this in the tool that we have with you. So again, this one is different because this is from the original document that we use to do the thematic tree. So we're not going to pass through all the elements. We can do this after if you consider that it's important to know. But for these elements, we didn't choose a specific number to include them in the tool. So most of the elements were included, except for those elements that were only 1 or 2 in occurrence. But we use clinical judgment to choose some other elements, like at the end here, active bleeding was only 2. So we included because we know that it was a sign of severe injury. So, for example, nausea and headache that you see here. So we also include those elements for the same reason. And then we just count all the we together all the interviews in 1 document. So that was 11 participants. So at the end, this was the first version of the tool. So it was in French, and some of the elements were modified during the validation phase. But it was really the initial version that was presented to them in the next phase. So there was a rectal checklist tool, and in the back there was some space to write a note and the protocol at the CRIUGM for falls. The second phase was the validation of the tool. So we did this by focus group. So the first focus group was composed by 11 healthcare professionals that reviewed the tool and provided suggestions for improvement. And then the second focus group was composed by 7 participants who evaluated the modifications made after the initial feedback, and then they also made suggestions. The analysis we did again by 3 by 2 professionals, and they were analyzing the feedback and to improve the tool again. We used some questionnaires after each discussion, and it was a questionnaire using a Likert scale to rate the tool. And at the end, we did again modifications, and we used all participants' combined expertise to make sure that the tool stayed relevant, work well, and fit into clinical practice. So the inclusion criteria for this phase were, we were looking for nurses working in long-term care at CRIUGM, but we wanted to be head nurse, coordinator nurse, head nurse assistant, or regular clinician nurses with a lot of experience, more than 15 years. And also from doctors working in long-term care for at least 2 years again, and doing on-call works in both pavilions. So for the participants in the 2 groups, so we had a mix of doctors and nurses again. The first group was 11 and the second group was 7, so for a total of 18 participants. So this is the question that we used for the questionnaire. So it was about, so it was a Likert scale 4 levels. And it was about improving practice about improving communication between nurses and doctors, about reducing administration workload that were related to falls, about improving management of falls in long-term care. It was good identifying risk for complications following a fall, about reducing care delays for patients who require transfer. Preventing possible falls, if it was user-friendly, if it was the overall satisfaction with the tool, and how frequently they will use the tool. We also had some open questions to this, and these were the elements that we just observed. So one of the questions was, what were the factors compromising the tool use? And there were concerns about increasing the workload and training. And other thing was the obstacles to implementation. So again, was resistance to change and to adapt new procedures. We had some feedback on usability and improvements. They suggest some ideas about design and format. And other question was about potential for broader implementation. So most of the participants think that the tool will be helpful for other facilities in CRIUGM. For example, rehabilitation centers and at home by a transfer medic. And but now there's urgent study that is very interested in using this tool for our paramedics doing visits at home. So these were the results from the validation phase. So the end was 18. And you can see it was a small number, but we consider okay to just give you the numbers in percentage. So in green, so here and this one. So it was a percentage found, the percentage of people found that it was very useful or extremely useful. So for improving practice, it was 83%. For improving communication between nurses and doctors, it was 100%. For reducing administrative workload related to falls, it was almost 75. For improving management of falls in long-term care, it was 94. Then identifying risk for complications following a fall was 89. Reducing care delays for patients requiring transfer 78, and preventing possible falls was 72. And at the end, if it was user friendliness for the instrument, it was 94, and the overall satisfaction with the tool was 94.5%. And how often they will use the tool, that was 94. So these were not the nurses and the clinical settings or in the care units. So these were the head nurses and the assistant nurses. Okay. So after that, we just had the final versions, which is a checklist tool in the first page. And then the space to write a note was bigger, and we had some other space to write the name for the notes. And we had also an algorithm, which was a protocol here at CRIUGM, but in a different way. So it was easy for them, and we gave this document, so the tool and the algorithm to the nurses for the next phase. So we used French version during the validation phase, but English version was developed but never tested. And other languages can be developed also, Spanish, Italian, and Portuguese. We continue with this project. So then it was the phase 3, which was the feasibility study. So it was a time to test the tool in our care units. So the participants were the care units. So in the Pavilion Containers, we selected here 2 units with patients at high risk of falling. So it was the wandering care unit and the unit for patients with behavioral disorders. In the other pavilions, so the pavilion after the Rocher, we included all the care units because that pavilion is more typical from us of in Quebec. For the study design, it was a prospective longitudinal study with a questionnaire again using a Likert scale for levels. And the comparative time frame was 3 months without the tool, and then 3 months while using the tool. J'ai perdu mon... Oui? Ah, okay, it's good. So how do we measure falls? So when a nurse operates the tool remains in the chart station. And after a fall, they must complete an incident report, what we call the rapport d'accident. This is available through an application on the computer. So we had access to these reports, and we also received a patient list from the nursing assistant. And so after that, we were able to just go and review the chart. So the questions were almost the same for as the validation phase. So some of them different was asking about collecting information from the chart. Others, like the decision making to contact the doctor, the answering doctor's questions, and how good was transmitting information to the doctor. And the others were actually almost the same. So if it was improving communication between nurses and doctors, if it was reducing administrative workload, if it was improving management of falls, and if it was good identifying complications following a fall. Okay. So we were looking for many outcomes. I present to you 3 of them here. So one was the usability, second the communication, and the incidence of faults. So by usability, we wanted to know if the tool was effective in collecting all patients' information needed to notify the doctor. By communication, we were looking to reduce the delay in notifying the doctor. And by incidence of fault, we expected a reduction in the number of faults. So for the first results about usability, so we had 31 participants, so they were all nurses. So out of 31 participants, we had 77.5 found the tool very or extremely useful in improving management. Then 77 found the tool very extremely useful in collecting all patients' information, and 21 for improving communication, and 68 for identifying communication. But overall, nurses were with less experience found the tool to be more useful. Experience was classified as less than 5 years, and 5 to 15, and more than 15 years. So it was better for nurses with less experience. So results about communication and efficacy. So this table compares information from before implementation of the tool and after. So about the number of patients who fall, so there were 36 patients before implementation of the tool, and 35 after. So for a total of 71 patients. But some of these patients fall more than once, and this is why the number of falls is higher. Because we consider a new fall after 48 hours. So it was 79 falls before implementation and 50 after implementation. So that was a total of 129 falls. And we think that it was a very important finding because the number of patients falling before and after the tool implementation was almost the same. But after implementation, there were less falls. So I think what actually happened is that the tool has reduced falls among people that were highly risk of falling. So for those falling times, then they were falling less after the implementation of the tool. So we wrote batches for to communication. So we calculate median from the number of falls when the doctor was notified. So as I mentioned before, we were looking in the reduction of the time to notify the doctor. So the median time to notify the doctor was 60 minutes without the tool, and it was 20 minutes with the tool. So that means the tool reduced the time by 40 minutes, so making it 3 times faster to notify the doctor. We haven't finished our analysis for these findings, so but because we should finish at the end of June. But we're working on the paper, and the information will be available soon. For the incidence of fall, we did tests. So chi-square tested indicated a statistically significant difference in the number of falls before and after the implementation. So the reduction in fall was 36.7 with an N of 39 and versus 50 after implementation of the tool. So some discussion implications about this tool. We compare validation phase to implementation phase to see if what was expected at the validation phase was really achieved at the implementation phase. So we compare both phases in 3 aspects. Was complaining about improving communication. So more than 70% rate the the tool to be very or extremely useful for improving communication between nurses and doctors. And in the validation, there was 100% for improving communication. About reducing falls, so the tool demonstrated to be even more effective in reducing falls after implementation phase. And for management of falls in long-term care, so over 77.5% of users in the implementation phase find the tool very or extremely useful. So showing its value in long-term care to reduce, like to improve management of falls. Some implications of our findings. So the first was enhanced communication. So improved communication between nurses and doctors leads to faster and more accurate intervention for our patients. So the standardization of care. So by this approach across shifts and personnel, we can be sure that patients will receive consistent care no matter who is on duty, which is really helpful to maintain high standard of care. This will reduce variability and the patient errors. Other implication was the increased efficiency. So the tool reduced administrative workload and so staff can focus more on patient care and improve overall management. And at the end, there was support for preventative measures. So the tool doesn't directly stop falls, but it does make communication better and care more consistent. So this reduces falls and promotes a safer environment. So some of the challenges and limitations that we found, so 3 aspects were identified. So the first one was resistance to change. So which is really common in settings with well-established routines. The other one was increased role of concern. So it's really important to make sure that it's very easy, but training was only 30 minutes to explain how the tool was created. And so no training expertise. One of the limitations for this study was the study design for implementation phase. Because we used 3 months before and 3 months after, so many the staff became more aware of 4 weeks. And then the tool didn't work as a preventative measure, and this kind of made the reduction in the incidence of fall. So there's a call to actions, so we need to evaluate the impact on clinical outcomes like the fall to improve communication. So different directions include implementation of the tool in other long-term care facilities with continuous refinement based on ongoing evaluation and the transition to digital platforms. So just a special thank you for all the residents working on this project and also for the research professionals. So we'll just finishing the analysis, and so these are all the residents that have working for us. And I have also my 2 residents right now here ready to for the next step. So thank you. So.
Thank you, Naya. Now it's time for a discussion, but I would like the priority to answer the opinion. And you can ask that video question either in French or in English.
Thank you so much. Congratulations on the fantastic project, and congratulations on your learners as well. That's really terrific, and I know how difficult it is to do a project like this, especially during COVID. So well done you. I had a couple of questions, and first of all, you did touch on the decrease in falls, and I was wondering if you could speak to were you able to look to see, did it trigger any prevention factors? Did you look at kind of what they did to try and prevent falls, the individuals that were assessed? Do you have that data that you're able to look at?
So I don't think we have this information yet. So we don't really know why the incidence of lodges reduced. Oh yeah, that's that we need to explore.
Well, I think in your next phase, that could be something that you could explore, because I think it's really interesting to think about, like what triggered people then, like did they were they more attentive, did they start implementing falls prevention strategies? So I think that would be really interesting. You said that it enhanced there's more efficient transfers of patients to the emergency room when necessary as well. And I was wondering if you could speak to that. Did you send the tool that was completed with the patient to emerge? And are you able to find out from the emerge staff what their perspectives are as well?
So yes, the patient was transferred with the tool, but in the first, because it was not very often. So in the first phase without the tool, it was only 3 patients transferred to the emergency, and in the second phase it was 4 and 3. So it was only 7, so I don't think I have more information about that. So, and I don't have the feedback from the hospital. But yes, the tool just followed the patient.
Great. Because I think that the information on the tool would be really helpful for the physicians and the nurse department. So that again, you scale it up and you're thinking about other outcomes. That's a nice spillover effect. Because a lot of times when we're doing implementation, we think of our primary outcome, but there's also these secondary outcomes that are spillover effects that could be quite helpful. And that if it makes there's information that you collected here that maybe inform the emergency department. And so that could be something you would potentially look at in the future. And I
did take
or it's ask a couple other questions. Sure. It's just a great project. So anything on falls is near and dear to my heart. So thank you for doing it. What strategies do you use to implement the tools? So you mentioned education.
Yeah, I did mention that. So that was a toolkit. So it was a special kit that we just installed on the wall. And all the documents were there. And there were also some chocolates for this time. That's why they were feeling completing the tool. But that's so we installed the same documents in each unit. And that was one of the strategies. So we did training at the beginning, so for the shifts, evening shifts. And so training was 3 minutes and the toolkit. So that was all.
And so then to sustain implementation, have you thought about what strategies you're going to improve? So like the staff turnover and
yeah, well, sure, the challenge was really successful. So I think that was the first one, but I think it was the same. Just having all the documents together. So the documents that they need to, and there was a big poster saying falls. So it was easy for the nurses to just know where to find the documents.
Maybe that's why how you bolster that's it, because often it is like a sugar high in English. The strap fire, I don't know. Okay, and that's you and use it, and after a while, I don't know, I won't bother. And what do you think that improves the most with the nurses and the other one? Is it they saw something new that they didn't know, or it was they changed their way to follow the people. You don't have any idea in how it changed the practice in the day-to-day. I don't know if our nurses was involved in that, in the flow. Do you know, Dinah? Do you have any nurses?
But it was really very easy to have the checklist and the patient just fell. So all the information was in just one document. So they didn't need to think about looking for what information to look at. Everything was there. So just the standardized.
And then probably there will be a lot of questions about the development of the tool, because there are a lot of steps. I probably in the crowd, there's a lot of people going after all the steps in the development of the tool, and after that, how to review it. Any questions from the crowd? Okay, Anna.
Merci beaucoup bien pour cette présentation tellement claire et importante. Maybe I should ask the question in English. Well, I'll ask it in both languages. My question is, you know, I'm interested in communication, and you said that the tool improved communication within the staff between the doctors and nurses. I was wondering if in your interviews, digging into what people answered in the questions, there was any specific aspect of communication that was important in your tool, in the communication. For example, was it that communication was improved because all the elements that needed to be looked at were just there, and everybody was looking at the same things, and then this facilitated communication between shapes and also with the doctor? Was it because I don't know, because there was this chart here, this logic chart, so that people would follow different steps equally? What was it? Was there anything specific in the way the tool was built? Est-ce qu'il y avait un aspect spécifique de cette échelle qui favorisait la communication entre la chute et les infirmières et les médecins? Quelque chose dans le format de ce que vous avez postulé dessus là aussi?
Yeah, well, not about the format, but the concern from nurses at the beginning was they don't want to go to the doctor for nothing. So so I know so in the open questions there were a lot of concerns about give me just the specific information when do I have to notify the doctor. So that's what we just suggest in the tool. So when one of the items was checked. So we suggested to inform the doctor. And because of these concerns, we add one of the things that we included in the checklist was the clinical judgment from the nurse. So, and this is why it was just an open question, so the nurse just can decide when she wants to have the doctor. But I don't know if I answered the question better.
Yes, you do. I think it's very interesting what you point out about the nurses being concerned with not bothering the doctors. And maybe this helps also to systematize and to somehow give the nurses the permission to feel free to contact the doctors, which is, I mean, very important in itself, apart from the qualities of the tool itself.
And this is why we use notifying the doctor as the measure to assess communication. Because many times they were just not calling the doctor and there was a big delay. So now that they know that they contact the doctor for the good reason. So then we improve the time of residence.
Thank you. I would like to ask you a question to get something done. You know, you're a geriatrician and you want to influence the care of the older people in the hospital. How are you dealing with your other colleagues from the other discipline about improving care? Is it by the research? Is it by having your trainees? What is it?
So it's a great question, and I've noticed a big change over the last probably 15 years, and in particular, more and more other specialties are interested in developing collaborations with geriatrics. And I think because as their population is getting older, they're recognizing the need for expertise from a geriatrician, but also understanding that there are opportunities for research. And so for example, one of the first initiatives that we did when we first started at when I first came to St. Mike's was we're a trauma center. And the trauma surgeons came and said, more and more of our patient population that we're seeing on the trauma service are older adults with falls, but also with motor vehicle collisions and things, and they have worse outcomes than the younger patient population. So together then we developed a proactive trauma consultation service and evaluated and went along some of our amazing pediatricians and the maintenance, a trauma surgeon, and it kind of spilled over then that, then I went to ortho and then CV surgery. And so I find that, the other clinical areas are starting to get more and more interesting. The thing too is, as their parents age, they're reaching out more and more as well. But I also think it's because, in Canada, as we've all seen, our population overall, portion of older adults is getting larger and larger. And also the complexity of the patient population. And so that's actually been one of the really big facilitators in terms of developing research and developing research collaborations. So a lot of times now we do research with all different clinical disciplines, and even in pediatrics. Like I do a lot of work with pediatrics as well, and it sounds a little strange to think why geriatrics and pediatrics, but it's the multidimensional factors of complexity, parents and children, just at different ends of the spectrum. So we do a lot of work with pediatrics as well and answering similar types of questions.
Just a sub question. A sub question that are you at the point that they are collaborators, so you educate them and you're not the resident of the other specialists?
So that's a great question, and it does depend on the service. So some of the ones that are kind of further along, our partnerships further along, like trauma, they're very much kind of in the lead. There's a lot of the trauma surgeons who rotate with us. Some of them have done research fellowships with our program and things. So they're at a kind of different phase, and some of the other ones are earlier on. Same thing with all of our colorectal surgeons and the ones who do oncology. They're more and more sending their learners to spend time with us as well and doing research projects with us. And then we co-supervise on their PhDs or on their master's projects as well. And I think that's actually been one of the most rewarding things.
Alors, est-ce que des gens pensaient des questions? Oui.
I'm really interested in intersection, and I was just I was wondering how you consider all the factors like language barriers, or social and economic factors, etc., in your implementation strategies.
Thank you. So great question, and one of the things that we try to do, so we use the Progress Plus factors when we're doing any kinds of data gathering, and we do it with, and we always do research using a co-creation approach where we have people from the development parties are involved right from the beginning. And we work with them to prioritize which are the data that we're going to collect, including which are the social determinants, for example, that we're going to prioritize to collect, because we may not collect all of them. It really depends on what the individuals prioritize. So we might, for example, prioritize race, language, or gender, depending on the various individuals and the particular time. So, for example, with our older adults experiencing homelessness, more older adults, look at those who are using shelters, it tends to be men. But if you look at ones in who are kind of transitional or more precarious housing, it tends to be more women, and they tend to be under-recognized. So we're trying to sample in those ways. And again, it's because of the patient partners who identify that. So that's kind of what they're interested in exploring. So we do it that way so that we're not going to necessarily collect data on all. But does that sound reasonable?
That's us. We have among us some geriatric psychiatrists, and we find that this population in our hospital is really the poor look at the population. What do you think? What are your opinion about that?
So one of our closest partnerships is with geriatric psychiatry, and we always talk about how there's so few geriatricians, but I worry about geriatric psychiatry, and we need more and more geriatric psychiatrists for sure. And in particular, one of the things that we partnered with our geriatric psychiatrists on are our outreach to the shelter system, for example. That's one of the initiatives that we partnered with them on. The second one, I think, is we're going to have to think about it, and I'm sure you're all thinking about it as well, with the new dementia medications that are coming down the pipeline, right? We know that there's at least one that's getting considered by Health Canada for approval right now. And how are they going to get implemented? So even if the Canada doesn't get approved, we know the next one, there will be one that gets approved because there's two that have been approved in the US. And as you all know, we haven't had a conversation on how we're going to implement these medications. And this is going to require a lot of resources. They're not inexpensive medications. They require a lot of diagnostic testing and monitoring, not counting the clinical side of things. Who's going to be doing it? Is it going to be neurology, geriatrics, geriatric psychiatry together? How are we going to access PET scanning and MRIs for everybody? When do we stop the treatment? There's so many things like that, and that's one of the things with our geriatric psychiatrists, we've been spending a lot of time lately talking about this and thinking about how do we prepare for this? How do we plan for it? Because our patients are asking about it. Like they're in the news, everybody's been hearing about it, and they're approved in the US, and Europe didn't approve them, but everybody's kind of waiting, and it's going to have workforce issues. It's going to have cost implications, and I'd be interested in hearing kind of where you are in the pathway thinking about it.
Yeah, it is like not the pandemic of COVID-19, but something for a geriatrician and neurologist, which is about insulin too. Yeah. Okay. Other question, other field?
Thank you so much. As a context, Quebec is now engaged into the dissemination and the inclusion of the electronic health records in Quebec. It's complicated and so on and so on. So I was wondering, Dr. Straus, to what extent the kind of studies you did will have an impact on the electronic health record, and maybe Dr. Cruz, if you are thinking of potential impact and contribution to improve the, we'll see something we need that will come, it will be useful because I suspect that some of the nurses, if the doctor had to be informed it was not here, the form that was sent was maybe sent by fax.
It's a great question. Yeah. Go to the first one. It's a great question. Thanks for asking it. And so at St. Mike's, we're just in the midst of rolling out the new electronic health records. So November 30th, we're going to be going live with Epic. And so it's at the top of mind for all of us. And but it's interesting, our long-term care homes are not. And we have a long-term care home that's affiliated with St. Mike's and a lot of people say use it to run into the system. So, so a lot of our work has been done in advance of that and thinking about what are the things that we can build in and implement. And so we all know the initial implementation stages of Epic is going to be painful, but we're all really excited about the next phase and what we're going to be able to do after that. To that end, some of the projects that we've been doing, just before COVID, we started a project where we, one of my worries with is with using data from the electronic health record is we don't necessarily collect data on social determinants of health. Like, so for example, I can tell you in our current electronic health record at CMICE, we ask people's religion, but we don't ask gender. We don't ask occupation. We don't ask anything else. And we're using, we've got a very rich AI program at our research institute led by Mom and Adani. But our AI tools are only as good as the data we collect, right? And if we're not collecting data on social determinants of health, we are at risk of increasing health disparities. So one of our projects that we're just kind of preparing for publication now is as an led by patient partners, is asking people when you come into hospital, how best should we ask you about gender and and race and age, and when should we ask you and who should ask when that information gets included into an electronic. And so a lot of times when patients come into the emergency department, that's when they're getting asked about, what religion are they when you come to see nights. And I'm not sure that's the best time to ask these questions are all just me, but it's thinking about that. And so we've got that project, and then we've got some other projects. One of my PhD students is doing a project on bias in AI. And what are potential interventions to mitigate bias in AI, and goes back to the types of data collect, but also on how tools are being developed. And then the other big thing that we've got some work on is there's a lot of tools being created, a lot of AI tools being created, but they're not necessarily getting implemented. And so again, it's a source of ways that we're not implementing and how best can we implement. So for anybody who's interested in any of these areas, like it's a wide open area, and so cute. I would encourage everybody to think about it. Like it's a great question because there's so many different things that you potentially add, and we're happy to collaborate if anybody wants to work on any of these together as well. Yeah.
And so for us, yes, so when the tools are ready, so we want to develop our electronic version of the tool so we can be sure and be available everywhere. So because it was we created a tool like for a setting with no doctor. So it could be really good for one that is home.
For both of you, here there are the students, graduates. Do you have some advice, Diana, like a clinician doing research with your student, and you being a researcher, a clinician, and doing research with the next generation? Diana, is it like Dr. Straus said, you see patient and the patient gives you some cue to what to do and you want to help them? Was it like this? Did you grasp an opportunity and
yeah, so yeah, I was thinking about the answer. So this was something that happened from the on-call wards every day. So communication was not optimal, so information was not the best. So we really wanted to improve this the communication and information that the nurses were giving during the ward. So it's good to try to find solutions for our daily problems. And I think this was only the opportunity to just create something that can be useful for everybody. So just go for it. If you have the phone, just think and how to find the solution.
I think it's such great advice because I think it's so important that everybody follows their passions, do the things that you really enjoy doing and that excite you, and being able to ask and answer questions that are relevant to our patients and their families, and and being able to then use that evidence in practice and in policy making. I think is again it's a tremendous privilege. I would also say, don't ever worry that, a lot of times, sometimes people think they have to fit in a box and they have to, like you can fit in a certain slot and you have to do a certain type of research or you have to stick to a certain area. And I remember when all through my training and my early career, everybody always said to me, pick a disease, pick a disease, pick a disease, pick an area of focus, pick a method of focus. And it wasn't until I went out ready to my research training and had a really fantastic mentor, Dave Sackett, who said, you don't have to pick a disease, you don't have to fit in a slot. And it sounds strange that somebody had to say that to me, but that was really important. It was to know that I didn't have to stay in a certain area, that you could follow the questions that came from the patients that you interacted with, the learners that you interacted with. A lot of the work that I've done in gender equity and gender disparity came from the learners. That people said, like I gave grand rounds one day, and this is one of the people in the audience came up to me and said, "You were the first woman clinician scientist I met." I thought, I didn't know. I was like stunned because I thought, how is this possible? This was a new person who just been recruited to the university, and said, she was recruited. She had 17 people on the list to meet, and not a single woman to meet. And that kind of triggered my interest in looking at that and thinking, how do I contribute to that, because I am a clinician scientist, and so you never know which direction your research is going to go in, and that's okay. So I just encourage everybody, do what you're interested in, what your patients are interested in, and it doesn't have to be perfect, because it will never be perfect, but we learn every single time, and we're better.
And I think that's the way that I into you had ideas. Here there's a research center. There are people there who said, yes, we can support you. We have this idea. And one thing interesting, which is Dr. Straus, that's exactly that. As you have an open mind and you have skills, you can transfer that to many subjects. So it's actually question? I could ask you what's the ratio of men and women as professor at the University of Toronto? I answer that.
So I can answer you that, because then that was actually one of the first projects we looked at. Because I wanted to see kind of what the numbers were, and then we looked at our research institute at St. Mike's, and at St. Mike's we had 8 times as many men clinician scientists, all scientists overall as women. And if you look across the different job categories, we have twice as many in our University Department of Medicine. University of Toronto Department of Medicine, there's 1,000 members in our department, and with twice as many men at the full professor level as women. But
over the last 8 years, we've worked to address that, and we've accelerated the number of people, the number of women going through the promotion at all of this. And that's part of, again, you know, if you don't have the data, you don't know what the issue is. So we started with data and we developed different programs, including a mentorship program that we've implemented to address that.
So I'm going to ask you a really practical question. I've been working in knowledge management for several years, almost. And one thing I noticed in the health environment, health institutions, is the availability of clinicians, practitioners to participate to the evaluation of the tools of the studies that are done for different questions. It can be really administrative and there's no liberations or side liberation or things like that. How do you manage around that? Because you need time to do that, to devote time to those different steps. So it's for both of you. How do you manage that? That's the answer for your study.
So it's a really great question, and nobody ever says they have too much time or too much money. So, those are barriers that we always encounter. And some of the strategies that we found to be helpful is identify who the opinion leaders or champions are, and who it is for trauma is going to be different for who it is, you know, ortho. So I think it's really spending the time figuring out who those individuals are going to be, and they're going to change over time as well. So we need to monitor that over time. It's also understanding what the facilitators are. So what's going to make their job easier, and making sure that that's kind of prioritized, that they're driving the change as well. That they're not seeing this as something that's imposed on them. You know, I would say that you know, for sure implementation strategies are going to fail if it's something that's very top down that gets imposed on people. You know, that they might initially do it, but that, you know, will tail off. So I think it's really finding out you know, what are the facilitators and what are the key issues that the clinicians are facing. You know, that we can work with them on to make patient care better, easier, more efficient, and getting them engaged in that way. Then there's also opportunities, and we've done partnerships with like C grants and things like that, you know, and accessing different sources of funding to facilitate clinician engagement. So we have the C grants can be made available that gives a little bit of money that clinicians then will makes it happen for clinicians to engage. The other thing I would encourage people, can you access the health systems fellowship program at CRIUGM? So that's a terrific program that we need joint sponsorship from an academic and a healthcare administrator, and then that person gets embedded within the organization. And we put up a program for those individuals, and that's been incredibly helpful as well. And they can also be then effective for change. So it's, I don't know if you study that program at all. There's need to use it at a fellowship level or practice level. But we found that to be helpful. Then got our possible events to say they liked it enough that they want to kind of start something similar. So
the issue with that is often it's for researchers or for clinicians, and there's an in-between that is not funded anywhere. And I'm not debating about that, but that's the reality of the present. It's a new profession. That's actually my job for like 10 years, knowledge translation and knowledge management. And it can be a difficulty because you don't enter any of those programs. So you have to find the people that can enter those programs to find the to have those finance response.
Partners.
Yeah, exactly. No, for sure, partners, and maybe we can chat afterwards because so my knowledge translation program, we have a number of individuals who have job descriptions like you, and we have diverse sources of funding. So we have grant funding, we do a lot of contracts for governments and things like that, like for provincial government, local government, or things. And that's how we fund these positions. I'm a big believer in diversifying resources funding, because you should never count on a single source. And but I'm happy to chat with you about this afterwards, about how we kind of create that model.
Well, I feel that for clinicians is really hard because we have duties to respect with treating patients. So actually, working at teaching hospital is what really helped for me. Because it's very hard for us to work without our researcher. So it's really, very important just to have this connection with someone and help each other to do these kind of projects. But it's not easy. I think if I was not working in a teaching hospital, that would be really just not opportunity for me to do research here in Canada. I'm still looking for how we can improve this.
Non, directeur Nadar, la directeur du département de médecine de l'université.
Sure. I'm just going to ask you a question about training programs. How do you see the future of training programs in communication science, especially for our physicians or younger residents? How do you see the training we should require in communication science?
So it's another great question, and I would say it depends. So I do think if people want to be an implementation scientist, I'm a big believer in doing graduate training and doing PhD. If you want to be an implementation scientist and you want to be competitive for CRIUGM grants and things, and frontiers grants and things, then doing a PhD. And also in a postdoc as well. For people who are clinicians doing it, I think it's helpful to do it after your clinical training, because then you can do your thesis and everything in the area in which you're going to be doing your work eventually. I've had students who've done the MD PhD program, and one of the things that I found that they have struggled more with picking up their research after they do their clinical training. Whereas people who do their clinical training first and then do it, I find that they find it much easier, more seamless to be able to do it. For implementation science, we have a national training initiative that we launched more than 12 years ago now. And we do annual summer institutes. And as one of the first steps we did was we looked across the country at who's got graduate training programs, what courses, and tried to fill the gaps in. A lot of the universities now have graduate training programs, but there might be gaps still. And if there's a small university, for example, they might not have the methods courses available. So our summer institute then trying to fill some of the gaps. And the Summer Institute is open if anybody's interested. The next year it's going to be in Vancouver. We're trying to east-west every year. It's going to be in Vancouver, but it's very much focused on graduate students, fellows, and people within their first 5 years of training, or first 5 years of some research, and helps them kind of develop their skills that they need. But also the cross-cutting thing is on mentorship and career development. So to me, that's another piece of the implementation science training, because a lot of the work that we do is cross-disciplinary, and it's not, some of the genealogists who does lots of different things. And so I think it's about developing knowledge of those different disciplines. And so if you look at the people who come to our summer institute, we've got people from architecture, psychology, clinic, like you name it, they come because everybody's interested. And again, the other benefit is you learn kind of how to develop those collaborations, but then you also learn to draw on those other literatures as well.
Thank you. No other questions? So I think I want us to applaud our two et je pense que le Transfert, c'est à quelques minutes si certaines personnes veulent lui parler dans le couloir. Merci à tous de votre présence. C'est vous qui faites finalement que les gens font, c'est important. Merci.